On a busy CCU morning, we encountered Mr. A 68-year-old with hypertension and diabetes, admitted for an anterior ST elevation myocardial infarction. He underwent fibrinolysis at a peripheral center before transfer for routine post-MI care. For 2 days, Mr. A was stable with mild chest discomfort, maintaining oxygen saturation and trending down troponin levels. However, today, the night resident reported a sudden and alarming change. He suddenly became short of breath and hypotensive. You rushed to the bedside, observing his blood pressure at 78/48 millimeter of mercury, heart rate at 122 BPM, and oxygen saturation at 88% on 6 liters via nasal cannula. His lungs now present with new crackles bilaterally, and a harsh, loud, pansystolic murmur is audible at the left lower sternal border, radiating to the right. This murmur was notably absent yesterday. Additionally, his jugular veins are distended, and his extremities feel cool to the touch. Instinctively, the thought arises, something ruptured. But the crucial question remains, what exactly ruptured? Sudden shock following a myocardial infarction can stem from various culprits, necessitating a thorough diagnostic investigation. Let's interrogate the suspects, starting with suspect 1, papillary muscle rupture leading to acute mitral regurgitation. Clues for this condition typically include an inferior MI, a soft, blowing murmur best heard at the apex radiating to the axilla, and often no thrill. However, our patient's murmur is harsh, loud, accompanied by a palpable thrill, and most prominent at the left lower sternal border, which does not align with papillary muscle rupture. Suspect 2 is free wall rupture, often seen after a large transmural anterior MI, typically occurring around day 3 to 5. Patients with free wall rupture present with sudden electromechanical dissociation or pulsus paradoxus, muffled heart sounds, and notably, no murmur. Our patient, however, exhibits a distinct murmur and lacks signs like pericardial rub or muffled sounds, thus dismissing free wall rupture as the cause. Suspect 3, recurrent ischemia or extension, could cause shock, but typically not with a new loud murmur and thrill. The ECG shows no new ST elevation, making this an unlikely diagnosis in this specific scenario. Suspect 4, right ventricular infarction, presents with hypotension, jugular venous distension, and clear lungs. However, our patient has crackles, not clear lungs, and the murmur's intensity is too significant for an RV infarction, ruling this out. Finally, suspect 5, ventricular septal rupture or VSD. This diagnosis perfectly fits the observed pattern. VSD typically occurs 3 to 5 days post-MI, when necrotic septal tissue gives way, leading to a harsh pansystolic murmur with a thrill at the left lower sternal border. It also presents with acute pulmonary congestion, shock, and a step up in oxygen saturation between the right atrium and pulmonary artery. Your mind clicks. This is it. The pieces of the clinical puzzle align, pointing towards a ventricular septal rupture. To confirm the diagnosis, an urgent bedside echocardiogram is performed. The echocardiogram reveals a defect in the interventricular septum in the mid-anterior wall with a left to right shunt. It also shows a left ventricular ejection fraction of 35%, a mildly dilated right ventricle, and no pericardial effusion. A right heart catheterization is then requested to further confirm the findings. This confirms an oxygen step-up between the right ventricle at 75% and the right atrium at 65%, alongside a low cardiac output. The diagnosis is now definitively confirmed, post-MI ventricular septal rupture. Cardiothoracic surgery is immediately alerted, and an intra-aortic balloon pump, or IABP, is placed to reduce afterload and shunt fraction. Vasopressors and oxygen support are initiated to stabilize the patient's hemodynamics. Despite maximal support, Mr. A's condition remains critical, necessitating urgent surgical closure, which is the only definitive treatment. Remember these key clinical clues. A new murmur after MI always indicates a mechanical complication until proven otherwise. A thrill at the left lower sternal border should strongly suggest a VSD, and the combination of shock, pulmonary congestion, and a loud murmur points directly to a septal rupture. Even without new ECG changes, a post-MI complication remains highly possible, and a rapid bedside echocardiogram is the fastest confirmatory tool. Always auscultate daily after a myocardial infarction, as new murmurs are critically important indicators. Post-MI mechanical complications often emerge precisely when patients appear to be recovering, underscoring the need for vigilance. Rapid bedside echocardiography and right heart catheterization are essential for clinching the diagnosis. Early surgical repair offers the only real chance of survival, as delay is deadly, with mortality approaching over 90% without timely intervention.